Welcome back to Conceptual OBG. This is Dr. Aditya, your tutor for tonight, and today I'm going to be taking you through a topic that used to be a thorn in my flesh since my undergraduation days. So it took me quite a while to get a grasp of this topic, but when I did, I realized it was an absolute cakewalk. When I say a cakewalk, today the next 2 hours or so are going to be me helping you do the same and helping you think the same about this topic. Urinary incontinence, a topic of utmost importance in females and a topic that is often ignored, or rather a complaint that is often ignored in several patients. Today I'm going to be talking about each and every aspect of it. The objectives of my session are going to be, first of all, I'm going to be talking about the anatomy and physiology. After that, I'm going to be talking about the pathophysiology of urinary incontinence. Next is going to be the diagnostic tests. I'm going to be talking about urodynamic studies as well briefly. And when I say urodynamic studies, I want you to know that it is not purely a urologist domain. You can understand those tests. They are hardly anything. You just don't need to worry much about it. After that, I'll be going towards the management, where I'm going to be talking about the conservative management as well as the surgical options that we have. And I'm going to be detailing about all the surgeries that are there and making you understand them much better. So sit through me, and the next 2 hours are going to be uh, an amazing experience for you. I guarantee you that. If you ask me what are the sources that I have used, there are several, but my two primary sources are going to be T-Lens and Berek and Novak. So let's get started. When I talk about urinary incontinence, of course, for urinary incontinence, before I understand what is going wrong, I would want to understand what is going right for my body. So first of all, it is going to be the anatomy. So when I talk about the anatomy of the urinary bladder and the urethra, then from the outermost layer to inside, there are three layers in the urinary bladder. First of all, I'm going to be talking about the urinary bladder. The outermost layer is the serosal layer. The middle layer is going to be the detrusor. And the innermost layer is going to be my mucosal layer. Now, innermost layer as in the side towards the urine. Assume this to be the urine inside and serosa is the outermost side. So in the mucosa, there are three more layers, three further layers. The innermost layer, which is actually in contact with the urine, is the urothelium or the urinary epithelium. Inside that, you are going to be having the basement membrane of that urothelium, very important. And lastly, the most important part, in my opinion, when I talk about this topic, lamina propria. Now, lamina propria is something that to me was kind of insignificant throughout my MBBS, even during my first year of MBBS in microanatomy, where we had a mention of lamina propria so many times. I never considered it that important until I realized, or until when I read this topic in detail and I understood the minute intricacy and the significance of this layer. So, to be able to demonstrate, if this is my basement membrane and this is my urothelium, it's a single squamous epithelium layer. Note that it is continuous and there are no breaks in it. No breaks, as in if you see over here, there are absolutely no breaks, and the integrity or the continuity of this is very important when it comes to the topic of incontinence, especially urge incontinence. Below this is the urothelium, this is the basement membrane. Below this is my lamina propria. The lamina propria is a layer that lies next to the detrusor muscle. So the significance of this is that it is kind of a connection between the mucosa and the detrusor, and it contains lymphatics, blood vessels, and most importantly, the neural structures, the nerve endings. So whenever this epithelium is going to be damaged, or whenever there is a break in the continuity, the basement membrane will also give away, and eventually it is going to affect the lamina propria, or basically whatever is there inside the urine, all those toxins or infections or whatever are going to directly get in contact with this lamina propria. Those nervous endings or those nerve endings are going to be stimulated by those inflammatory factors like toxins or infections, microbes, whatever, and that is going to cause triggering or stimulus of this detrusor muscle. That is going to contract the detrusor muscle even when I don't want it to. What happens when detrusor contracts? You end up passing urine. So there is going to be an involuntary passage of urine, and this exactly is what happens in urge incontinence. I'll come back to this again later, but that is how important is this layer of lamina propria. So it is the innermost layer of the mucosa, and it contains all these neural structures. Now that I've spoken about the neural structures anyway, what is the nerve supply of the bladder and the urethra? So, when I talk about the nerve supply, it has a somatic supply and it has an autonomic supply. The autonomic supply is more important, but the somatic supply, which is kind of, you can say, as the voluntary supply to your bladder, is by the nerve root segment of S2 to S4, which also happens to be your pudendal nerve. This pudendal nerve is going to help you contract the external urethral sphincter, which is actually the manual sphincter which is in your control. So whenever you are, let's say, in a public place, and of course you do not want to soil your clothes, you do not want to involuntarily pass urine, this is the sphincter that is under your control, which helps you to voluntarily avoid urination despite you knowing that your bladder is getting full and you want to pass urine somehow. This is under your voluntary control. What is not under your voluntary control will be your autonomic nervous system. In that, you have sympathetic nervous system, and you have parasympathetic nervous system. In sympathetic nervous system, we have all heard about the adrenergic receptors. So there's going to be alpha and beta. Whereas in parasympathetic, it is going to be acetylcholine receptors, which, if I'm going to subclassify, it is going to be the muscarinic receptors and not the nicotinic receptors that are going to act. So whenever there is an increase in the sympathetic nervous system, basically whenever there is triggering of the alpha and beta receptors, the alpha receptors are going to work on the trigone and the urethra. They are going to be contracted by that. Whereas stimulation of the beta receptors, we all know, by the way, that alpha receptors cause constriction, whereas beta receptors cause dilatation of all the smooth muscles in the body. So whenever there is a triggering of the beta mimetics or beta receptors in my body because of an increase in the sympathetic drive, at that point of time, my bladder is going to contract. So beta receptors in my bladder, rather my bladder is going to get relaxed. So it is going to relax. So what this means is that my urethra is contracting, so the passage of urine is blocked. My bladder is relaxing, hence this helps in bladder filling. Basically, my sympathetic nervous system is going to help me in filling of my bladder. The urine is going to be accumulated inside my bladder. Whereas in parasympathetic nervous system, there is going to be bladder contraction. And hence that will lead to bladder voiding or bladder emptying, whatever you call it. But I just said that this is a system that is not under your voluntary control, or in other words, it is an involuntary system. So if it is involuntary, you wouldn't want the body to decide where to randomly go and micturate. You are probably in your college and your autonomic nervous system just says that it wants to micturate right in the middle of a class. It cannot work that way, right? So there has to be something that controls this sympathetic and parasympathetic nervous system and keeps a check on where you are micturating. That is the work that is done by the pons. So in my brain, there is a structure that you all know called as pons. The pons contains the micturation center, what we also call as the Pontine micturation center. What it does is it keeps a check on the sympathetic and parasympathetic nervous system. How does it do? So whenever you, let us assume that, let us first think that whenever it is stimulating, there can be two options. Either you can be stimulated and you can pass urine, or there can be an inhibition and your urine is stored. So as I said, the stimulation is going to be through parasympathetic nervous system, whereas inhibition, that is bladder filling, is going to be by sympathetic nervous system. So what the body does is, whenever there is filling up of the bladder, you have had a lot of water or drinks or whatever, and your bladder is full, it will send a signal to the spinal cord. The spinal cord will relay the signal to the pons, and the parasympathetic nervous system is going to be deciding whether to micturate or not. The Pontine center will first assess whether you are in a surrounding where you can micturate. If you can surrounding, then parasympathetic nervous system is going to be activated and there is going to be bladder voiding. Bladder filling void. So whenever the bladder is filling on consistently, then the spinal cord is a very crucial cog in the wheel of this which will decide whether to void or not. But beyond the point, the spinal cord cannot take a stimulus. Let us assume, or not assume, it's a fact that your urinary bladder has a capacity of 400 ml. So whenever that 400 ml is going to be reached, at that point your bladder will know that I cannot any longer wait. In that case, the spinal cord, without asking the pons, is going to directly send a signal and it is going to cause maturation. So until a point, your spinal cord and your pons are going to maintain this balance between socially appropriate and inappropriate maturation. But beyond the point, when the capacity is too full, then it escapes this mechanism and the spinal cord will directly as a reflex cause urination. But the point to be noted is that parasympathetic nervous system is the one that is associated with bladder voiding, and hence we always say that micturition is a parasympathetic reflex. So that is how, with the help of pons and spinal cord, the balance between parasympathetic and sympathetic nervous system is maintained, and any defect in this, all this mechanism in any of the adrenergic or the acetylcholine receptors, cholinergic receptors, anything is going to lead to something called as urinary incontinence. Any problem in your spinal cord, in your brain, or in the local receptors, or in the pelvic floor, that is going to be leading to urinary incontinence. And as it is defined, it is the involuntary leakage of urine. Basically, it is going to be beyond your control. So what are the complaints that are going to be commonly? The patient is going to come to you and tell that the patient is getting too many urges, increased urge. She says that she's just sitting, she's doing some work, and suddenly she gets an urge to micturate. And by the time she reaches her washroom, she has already passed a few drops of urine in her undergarments. And that is a very embarrassing thing for her. So the first thing is they're going to say that I'm getting sudden urges. She said earlier, I used to get urges, but I knew that the urge was gradually increasing. And then I had time to go to the washroom, void, and come back. But now I suddenly get an urge and I end up passing the urine without my control on it. She also says that not just that, but even my frequency towards washroom breaks have increased. In fact, it is becoming very embarrassing for me that at my office I have to go to I have to go for a loo break, I have to go for a washroom break every hour, and that is very socially inappropriate and embarrassing for me to go every now and then. So the frequency of washroom breaks or urination increases. She says this is about my day. At night, I'm unable to sleep because every hour or 2 hours I have to wake up and go to the washroom. So there is an increased episode of nocturia. She says even this was okay, but recently at least I was getting up at night. It was disturbing my sleep, yes, but at least I was getting up and I was able to go to the washroom. But nowadays, in the last couple of weeks, I have even had a few episodes of enuresis. Enuresis is basically, she says that I don't even realize that I've passed urine and my bed is all wet. I get to know about it in the morning. So I've completely lost control over my urination. So these are going to be your major complaints. A few complaints or a few women will say that every time, I don't have all these complaints, but every time I cough or I sneeze or I try to strain while passing stools because I usually have constipation, at that time I end up leaking urine. She says earlier I used to sneeze, I used to cough. Of course, I had cough, sneezing as everyone does, but I never had the passage of urine. But now I'm even having passage of urine whenever I have these episodes. So increased stress induced urination. So these are going to be your major complaints that these women come to you with. This gives me a classification. This broadly classifies my urinary incontinence under 3 headings. First is going to be stress urinary incontinence. Next is going to be urge urinary incontinence, And last is going to be overfill or overflow incontinence. I'm going to be discussing about all of them, but my major discussion is going to be on these two today. So, stress, as the name says, that whenever there is an induced stress or there is an increase in the abdominal pressure due to any activity, the female ends up passing urine. So, what might be the reason? So, there are a few reasons or a few theories that have been postulated, and those theories have evolved over time. The earliest theory was the hammock theory. Uske baad mein we had something called as the integral theory, and now the recent most and the most widely accepted current day theory happens to be the intrinsic theory. So, what are those theories? So, when I talk about SUI first, the pathophysiology, the cause of all this to happen. The first and the most widely accepted theory today happens to be the intrinsic theory. The second most accepted is the integral theory. And the third most, but the oldest, is going to be the hammock theory. So what is the intrinsic theory? The intrinsic theory says that loss of the urothelium or the integrity or the intrinsic nature of the urothelium is going to lead to incontinence. What does that mean? I had already mentioned that if this is your basement membrane and if this is the continuity of your epithelium, if because of some reason it is going to be damaged or deranged, if it were to become something like this, and also if there was something like some break in this basement membrane, in that scenario, the lamina propria is going to be exposed, and not just the lamina propria, it is also going to lead to my exposure of the detrusor muscle. This is still okay with my bladder. When this is going to happen with my urethra, where the lamina propria is very less, this is going to lead to thinning of my urethra. जो मेरा urethra, let us assume पहले इतना था, it will become a little thin. This is going to lead to an increased mobility of my urethra. This leads to hypermobility of the urethra. So basically, a loss in the continuity of the urothelium is said to be one of the reasons why the urethra is moving a little too much, and the integrity, or what do I say, the compactness of that urethra, which was preventing the urine from flowing out at any duration, has gone lesser. So the urethral closing pressure has reduced. So now earlier, what my urethra used to be able to take a pressure of, let's say, 100 milligrams per mercury. Now it is only going to take a pressure of 50. So basically, पहले मैं cough करता था, urine pass नहीं होता था. But because of my damage to the urothelium now, even a pressure of 60 or 70 is going to lead to passage of urine. This is what the intrinsic theory says. So the intrinsic theory says that it is because of loss of urothelial integrity or urothelial continuity. We also call it as the urothelial coaptation of the urethra. Next is the integral theory. The integral theory says that your urethra is kept in a balance. If this is your urethra and if this was your bladder, it is kept in balance by anterior pulling forces and posterior pulling forces. So if this is my pubic symphysis and this is my sacrum, if this was my urethra and this was my bladder, I'm not drawing the uterus and rectum over here. So in this scenario, I had an anterior pulling pubo-urethralis muscle and a posterior pulling levator ani and pubo-cervicalis. So basically, there was a force from behind, there was a force from front, but these two forces would cancel out each other, and they would effectively ensure that my urethra is blocked. My urethra will be blocked so that the urine does not just flow through the bladder downwards, and it will ensure that there is a nice tone to it. These muscles are going to be damaged because of something called as labor or multiple pregnancies. Basically, this pelvic floor, which is actually made by all these muscles, including the levator ani, the muscles as I mentioned, the levator ani and pubo-cervicalis backwards, and anteriorly the pubo-urethralis. So ये जो forces है, these forces are going to be reduced. This pelvic floor is going to be weakened due to multiple pregnancies, due to multiple vaginal deliveries. This leads to an increased risk of the urethra not getting closed well enough and letting the urine out at any increase in stress in the abdomen. So because of a female, let us say, having had 4 or 5 deliveries in the past, now her pelvic floor is very loose and lax. Because of that, the urethra is lying mobile inside the pelvis, and wherever a female coughs, the urethra just opens up immediately. पहले वो एकदम बंद रहता था, कितना भी stress आ जाए ऊपर से, whenever there used to be coughing or sneezing, जब भी इसके ऊपर ऐसा pressure बढ़ता था bladder के ऊपर, वो फिर भी बंद रहता था. But now because of the weakening, it is lying open and urine immediately passes out. This leads to, or this is the second most acceptable theory of SUI. The last theory is the hammock theory. The hammock theory, which is the oldest theory, talks about a hammock. Now, this is a hammock that you can see. This white thing that you can see behind is the hammock. This hammock rests on some support that is given over here. So in this scenario, assume this hammock to be the anterior vaginal wall. And imagine this lady over here to be the female urethra that is lying. So this lady over here is going to be the urethra that is lying on the anterior vaginal wall. So if I'm again going to draw the pubic symphysis and the sacrum, if this was my bladder and this was my urethra and this was my uterus and this was my anterior vaginal wall. So the hammock is this anterior vaginal wall and this female is this urethra that lies on it. Now this anterior vaginal wall और ये दोनों के बीच में there is something called as endopelvic connective tissue. It is spread throughout the abdomen. It is there throughout the abdomen. It is also the tissue that we use while doing anterior colporrhaphy. This endopelvic connective tissue is going to be weakened again because of multiple episodes of delivery. So this hammock that you can see gets weakened. The fibromuscular anterior vaginal wall gets weakened because of multiple vaginal deliveries, because of multiple insults to it, which includes the passage of baby multiple times. And hence, in women who have an increased parity, this hammock is going to be lying loose. When this lies loose, this female is not going to be sleeping so peacefully on it, and she will have a risk of falling downwards or probably even going or being flung upwards. So basically, this is going to lead to hypermobility of the urethra. This female is not going to be able to sleep there stably, and this excessive movement of the urethra or the hypermobility of the urethra will lead to an increased passage of urine whenever there is any stress factor on the bladder, like cough, cold, or anything, coughing, sneezing, or anything. So the urine is going to be passed out involuntarily. So the hammock theory focuses again on the hypermobility of the urethra. So these are the three theories that talk about the SUI, intrinsic, integral, and hammock. All it talks about is सबसे पहले तो the continuity of the urothelium, which if it is lost will lead to an excessive mobility and decrease in the opening pressure of the or decrease in the closing pressure of the urethra, or the integral theory wherein there is a weakness of the pelvic floor muscles, and lastly the hammock, which is the weakening of the anterior vaginal muscular wall. This was about stress urinary incontinence. What about urge incontinence? What I've already mentioned at the beginning of this lecture. In urge urinary incontinence, there are two theories. The first one is a neurogenic theory, and the second one is a non-neurogenic or a myogenic theory. Now, what is urge incontinence? It is basically your bladder is randomly, involuntarily contracting and leading to passage of urine. It is out of the control. पहले जो जब भी चाहिए तभी contract होकर urine करना चाहिए था, अभी वो randomly कभी भी contract कर रहा है. Why should that happen? So the neurogenic theory says that whenever there is going to be any damage to the continuity of the epithelium, as I mentioned, this was my basement membrane and this is my urothelium. If there is any damage to it, and also if there is any damage to the basement membrane, then in that scenario, my lamina propria, which is there over here, is going to have those nerve endings that are going to be stimulated, and this detrusor is going to be hyperactive. So basically, whenever these nerve endings get stimulated because of something that is there in the urine, it can be an infection like a recurrent urinary tract infection, or it can be any toxin that is eliminated by the kidneys from the body. It is going to stimulate this, and the detrusor is going to randomly keep on contracting. So the neurogenic theory is also called as the epithelial hypersensitivity theory. You would ask me as to why should there be a damage to this urothelium, what we also call as the urothelial coaptation. Coaptation मतलब उनका जो ऐसा closely knit structure था, उसमें damage क्यों आना चाहिए? This happens very often because of repeated insults, like because of repeated UTIs or because of age. Now, this basement membrane, we all know that in women who are elderly, the skin gets wrinkled and all. What is the reason for that? It is because the collagen in them reduces. The composition of collagen changes. Why does that happen? Because collagen contains estrogen receptor. Those estrogen receptors have no estrogen now after menopause, so they are going to completely start getting atrophied. Similarly, the basement membrane also contains collagen, and a disturbance in this estrogen of normal body, which is basically what happens after menopause, is going to disrupt that basement membrane. This basement membrane disruption is going to lead to the lamina propria getting stimulated, the nerve endings getting stimulated. The difference between this and SUI is that there is a lot more disturbance in the basement membrane because of the lack of estrogen. Whereas in SUI, the basement membrane is fairly intact and the collagen composition still stays normal, which is also why urge incontinence is going to be seen in elderly women who are in their 50s and 60s and 70s, whereas stress urinary incontinence is going to be seen in younger women in whom the basement membrane is going to be intact. In women who are around the age of 50, you can even have a composition of both urge and stress, which we call as a mixed incontinence. Not for now, but you have to remember this is the reason why neurogenic theory says there is going to be excitation of the detrusor muscle. The myogenic theory instead says that this urge incontinence is not because of these neural structures only, it is also because of the damage sustained over years, over a period of long period of time to the detrusor muscle. How can detrusor be damaged? It can be damaged if if a person has atherosclerosis. Atherosclerosis से क्या होगा? There is going to be ischemia. Ischemia of what? Ischemia of the detrusor muscle. So there's going to be ischemic necrosis. So whenever there is ischemic necrosis, whenever there is less amount of blood that is reaching, there are going to be less number of excitation stimulus also that will be reaching. The nervous structures, the nerves that are innervating the detrusor, even they are going to be rendered ischemic. So what happens? उनको जितना भी थोड़ा भी stimulus आता है acetylcholine का, they are completely available to get sensitized and they become hyper excitable. So whenever you remember in your body, whenever there is an excess of anything, all the receptors get desensitized. Whereas whenever there is a decrease in the quantity of anything, they get highly sensitive and they can be sensitized at any point of time. So this ischemia is going to make them hypersensitive to even small amounts of acetylcholine. And hence, this ischemic necrosis is going to lead to hyperexcitability. Apart from that, they also say that if a female, probably she used to work in a corporate place where she did not wish to go to or she did not wish to use the washroom of that office quite far too often, she would just store up her urine for 12 hours, 14 hours. What that led to was, this was a bladder earlier, which had a capacity of 400 ml. She used to keep on storing her urine and it increased to 800 ml over a period of time. 12, 14 hours, she did not pass urine. She used to go home and only pass urine. This led to an increase in this size. Because of this increase in size, there was pressure necrosis, not ischemic, but pressure necrosis of all those nerve endings. Similar to what happened in ischemic necrosis, यहाँ पे pressure necrosis हुआ और वो pressure necrosis के वजह से उनका sensitivity बढ़ गया. So myogenic theory में उन्होंने वही बताया है that damage to the detrusor and the nervous endings are going to lead to this chance of this causation of urge incontinence. Apart from this, voluntary non-voiding, मतलब वो खुद से decide कर रही थी avoid नहीं करना है. If there was any reason for her urethra to get blocked, let us assume there was a fibroid at the cervix which was blocking the urethra as well, and it was not able to pass urine over a period of time. Urine used to accumulate inside her bladder. That accumulation of urine not only led to repeated episodes of UTI because urine is a rich medium for microbial growth, but it also eventually increased the size of her bladder. This again led to all the desensitization of multiple nerve endings, and hence the myogenic theory talks about this. So urge incontinence is all about knowing why the detrusor is overreacting, which is also why we call this as overactive bladder. The other name for urge incontinence is overactive bladder. This is about urge incontinence and stress urinary incontinence. So now that we have spoken about this, we have stress on one side, we have urge on one side. If there is a female who has both of them, which is very likely, at that time I'm going to have mixed urinary incontinence, wherein the treatment and management is going to include the management of both stress and urge incontinence. So these were the most common reasons for stress and urge incontinence to occur. Are there other reasons why there can be involuntary voiding of urine? Absolutely, there can be. There are alternative and other reasons as well. for incontinence which do not fit into urge or stress. It includes if you have something like a urethral diverticulum. What's a diverticulum? This was your urethra. This is more like a diverticulum that has formed, outpouching or an outgrowth. Why did this happen? It happened because there were multiple episodes of infections. UTI bar ho raha tha for her to a female because let's say she was a diabetic or because she had poor voiding habits or whatever, or use of public washrooms again and again. This led to a continuous disruption of the basement membrane, the urothelium, and eventually the basement membrane just gave away and it formed a pouching like this. This pouching kept growing until it started leaking urine from it somewhere else. So urethra पहले जो ऐसे हुआ था, अभी the urethra is leaking from this point. तो यहाँ से जो यूरिन बाहर आ रहा है, this is called as a urethral diverticulum, very much like your intestinal diverticulum that you have learned like Meckel's. Next, you have an ectopic urethra. Ectopic urethra is basically a urethra that is not opening at its usual external urethral meatus, it is opening elsewhere on the anterior vaginal wall. Next, you have your bladder exstrophy. What is bladder exstrophy? Basically, your anterior abdominal wall, you have your anterior abdominal wall, the bladder should be inside of it. But instead, your pubic symphysis is opened up and your bladder is outside the body, which is going to keep on leaking the urine. It's a congenital anomaly and it needs to be repaired and the bladder needs to be placed back inside. So, bladder exstrophy. It is basically the bladder is outside the anterior abdominal wall. It's a congenital anomaly. It can be associated with several syndromes, by the way. So the patient might have other systemic effects as well, other systemic problems as well. Apart from that, you can have a urethral fistula or urinary fistula is a better term. Urinary fistula is a better term. So what can be various types of fistula that we have read before? So a fistula can be, let's say, a vesico-vaginal fistula, or it can be a vesico or uretro-vaginal fistula. It can be a urethro-vaginal fistula, or it can be Yusuf syndrome, which is that is uterus, vesicle, fistula, Yusuf syndrome. Anything, basically there is an abnormal connection between any part of the urinary tract to the vagina or to the genital tract, which is leading to leakage of the urine from some other part from the genital tract instead of the urinary tract. So a fistula, of course, it will require a surgical correction, is another cause of urinary incontinence. So when I'm talking about all these types, especially the stress and urge incontinence, what are the reasons which women are going to be at a higher risk of getting this? So the risk factors, as I promised, I'll be talking about each one of them logically. So first is going to be stress or SUI and the other one is going to be urge. And here I'm going to be enumerating the risk factors. So the first risk factor is going to be age. So when I talk about the age, I've already mentioned that in menopausal women, because of lack of estrogen, the basement membrane is going to be damaged. The basement membrane is going to be damaged, so the nerve endings are going to be stimulated and the detrusor is going to be stimulated very rapidly and again. That is going to lead to urge incontinence. So urge incontinence is going to be seen in women who are elderly. So age more than 50 years is a risk factor for urge incontinence. Similarly, age less than 50 years, these are those women who have had multiple vaginal deliveries, multiple children that they have delivered, and higher parity. Basically, the pelvic floor is lying all weakened out. So less than 50 years, I'm going to see more of stress rather than urge incontinence. It brings me to my next one, that is parity and pregnancy. So more the number of pregnancies, more is going to be the stress incontinence, lesser the risk of urge incontinence. Stress incontinence increases because, as I mentioned, the integral theory states the pelvic floor will get weakened because of childbearing. Next, it is going to be race. It is seen that in Asians, remember that in Asians, there is a higher risk of getting diabetes, obesity, and atherosclerosis. Basically, metabolic syndrome is very common in Asians. And I've already mentioned that atherosclerosis, hypertension, all these metabolic syndrome is going to lead to ischemic necrosis of your bladder detrusor. That is going to increase the chances of you getting urge incontinence. So race, basically Asian or Indian race is going to have a higher chance of having urge incontinence. But also remember that the parity status of Indians is very high. So I would not discount that fact that because of our high parity score, even stress incontinence is going to be at an increased possibility. So both are going to be increased in Asians, more specifically Indians. Apart from that, if I'm going to be talking about obesity की वजह से फिर से दोनों प्रॉब्लम्स आएंगी. क्यों दोनों आएंगी? Whenever there is increased obesity, the huge visceral fat is going to increase the pressure on my pelvic floor. Pelvic floor के ऊपर pressure बनने का ऐसे there is going to be thinning of my pelvic floor muscles. Also, there is going to be increased not just visceral, peripheral सब fat बढ़ने की वजह से जो अंदर का pudendal nerve है, that pudendal nerve which supplies my levator ani is going to be compressed. Compression of that pudendal nerve will lead to necrosis of the part that it supplies, that happens to be the levator ani. So the pelvic floor is going to be weakened because of obesity. But in obese patients, we are also going to have atherosclerosis, metabolic syndrome, hyperlipidemia, and hence urge incontinence risk is also going to be increased. Next, it is going to be diabetes mellitus. Diabetes mellitus, again, it is going to lead to microvascular complications. We have all heard microvascular complications like nephropathy, neuropathy, retinopathy, all these things. So the small vessels that supply the nerves, the vasa nervosa, those are going to be affected. That is going to lead to ischemia of the nerves, and the nerve endings that supply the detrusor are going to be damaged in diabetes mellitus. So an increased risk of urge incontinence is going to be seen. Also remember that diabetes mellitus mein there is an increased risk of recurrent UTIs, and recurrent UTIs are yet another factor which leads to urge incontinence. Lastly, if a patient already had stress incontinence and she has been operated, so history of surgery for SUI, it's a very special condition here. Remember, most of the surgeries for SUI include putting up a mesh or some rectus sheath or something inside the body so that we can support the urethra and the bladder neck. Now, this is more like some foreign body or a foreign tissue that I'm introducing in that area. Now, cut to a different topic completely. For all those who have seen a cesarean section, the ones who have used a cautery, a diathermy, जो हम cautery, monopolar cautery use करते हैं, कभी तुमने देखा है whenever you just touch your rectus muscle for a bleeder that is there on it, the rectus muscle suddenly contracts whenever you touch a cautery on it. Now, this is because of the stimulation of the nerve endings that are present on the wall of that rectus muscle. Similarly, any foreign body, whenever it touches a muscle or whenever it irritates a muscle, it is going to contract. Now, over here, you're putting a mesh or a rectus sheath or some fasciolata, some foreign body to support the neck of the bladder. This can lead to migration of that material towards the bladder, and it can keep stimulating the bladder serosa, and bladder serosa is going to transmit those irritations or the stimulations to the detrusor. Hence, the presence of that foreign body, it can be a mesh, it can be a sheath, anything, is going to lead to an increased risk of urge incontinence in patients who have been earlier operated for SUI. तो SUI के पेशेंट को रिकरेंट SUI हो सकता है, but the chances are less. But जो होने के chances ज्यादा है वो है urge incontinence. So this is going to be my explanation of all the risk factors of incontinence, stress, and urge. So how do I manage it? When I talk about the management, सबसे पहले मुझे diagnosis लगाना बहुत जरूरी है. And before diagnosing, I need to take a proper, very proper and meticulous history for them. So in management, my first part is going to be diagnosis, followed by second part being treatment. So diagnosis में सबसे पहले मेरा most important aspect is going to be history taking. The second most important is going to be physical examination. The third is going to be doing various tests to confirm my diagnosis. Those tests can be simple tests or they can be advanced or complex tests. So talking about the first part, that happens to be history. When I talk about history, what am I going to elicit from that patient? सबसे पहले मैं patient को पूछूंगा, are there any stress factors? Stress factors like, is the patient coughing recurrently? Does the patient have a history of smoking that has led to COPD? Or does the patient have bronchial asthma and she keeps on getting exacerbations? So are there any factors that are making her increase the abdominal pressure time and again. Another thing, does she eat less of fibrous diet, which is why she's having constipation and she has to increase the abdominal pressure to be able to defecate? So, is there any stress factor that is increasing her abdominal pressure? That is what I'm going to be asking her, because that will give me a clue about whether she has SUI or urge incontinence. That will point towards SUI more than urge incontinence. Next, I'm going to ask her about her complaints. Are they more of frequency or urge increase? Because if that is the case, it will give me an idea about urge incontinence, whereas here it was SUI. The third thing that I'm going to be asking her, if she has an increased episode of recurrent dysuria, burning maturation, which is basically signs of UTI, fever, does she have these episodes, which might give me an idea about urge incontinence. The next question that I'm going to be asking her, is she consuming any drugs? Now remember, a lot of drugs are going to have an action on the bladder. What are those drugs? The drugs can be sedatives. Basically, she's being put to sleep for too long. Probably she's getting an overdose of the sedatives. Those sedatives are ensuring that she doesn't wake up at night and she ends up just urinating in her bed. Also, those sedatives are going to lead to relaxation of the detrusor. Whenever they relax, the bladder is going to be overfilled. जब भी वो overfill होगा, I have told you, pressure necrosis के वजह से all those nerve endings are going to be damaged, which will lead to the patient having पहले overfill incontinence followed by urge incontinence. Or if she is consuming a lot of alcohol, alcohol not only causes sedation, but it will also cause increased diuresis. Next, I'm going to ask her if she is consuming any anticholinergic drugs. But you would ask, we don't even prescribe anticholinergic drugs. So kaise? Remember, there is an anticholinergic action in several drugs that you give for other purposes, like antihistaminics that you give for rhinitis, histaminics, cold के लिए देते हो. Or if you're going to be talking about antidepressants, SNRIs and SSRIs, उनमें भी रहता है, especially if you're giving tricyclic antidepressants like imipramine, उसमें रहने वाला है. So antidepressants, if you're giving any antipsychotic drugs, if you are treating the patient with any opiates, morphine derivatives, or if you're treating the patient for antispasmodics, for dysmenorrhea or intestinal pain, intestinal colic, all these things like cyclopam. So you have to ask them if she's consuming any of these. Why? Because anticholinergic drugs are going to cause relaxation of the bladder. Remember, cholinergic effect is going to lead to contraction. Anticholinergic is going to lead to relaxation. This relaxation will make sure that the bladder is not maturating even though there is 600, 700, 800 ml of urine inside it. This will lead to something called as overfill incontinence. What is overfill? वो इतना भर गया कि अभी खुद से लीक होना शुरू हो गया है. The capacity is exceeded, and eventually this will lead to damage, pressure necrosis of all the nerve endings and urge incontinence eventually. So overfill incontinence पहले and later urge incontinence will be caused by excessive or prolonged therapy with these drugs. This is what is going to be a part of my history taking. These 4 factors are what I'm going to be asking her. If there are any stress factors, if there is any urge or frequency increase, is she having recurrent episodes of burning maturation, dysuria, that is UTI, and if she is consuming any of these drugs. Next is going to be my physical examination. So when I do a physical examination, it is going to be my systemic examination and my very specific examination of the genital tract. So physical examination mein, first I'm going to be examining all the major systems. What are those major systems? सबसे पहले मैं CNS का examination करूंगा. I will look whether she has dementia, because dementia and she forgets to void time and again, or if she has something like multiple sclerosis, whereas there is demyelination, there is destruction of the white material, and hence her somatic nervous system, that is a pudendal nerve, is not acting well enough. It can even affect her autonomous nervous system. The spinal cord is going to be affected. There is going to be degeneration of the spinal cord, and hence the autonomic control over the bladder is going to be lost. Or if she's having Parkinson's disease and she's consuming any of these drugs. Next, I'll be seeing her cardiovascular system. Why cardiovascular system? Because if she is having coronary history of IHD, that is ischemic heart disease, will lead to me thinking that she has had atherosclerosis in her body in the heart. Very likely that even the vessels that are supplying the detrusor are going to have atherosclerosis. Apart from that, if she has any vasculitis or vascular problems, vascular diseases. Next, I'm going to be checking her respiratory system, whether she has COPD, which leads to recurrent coughing and stress urinary incontinence. Then obesity is going to be very important thing that I'm going to be checking for her BMI. And lastly is going to be her pelvic examination that I pelvic examination I'll write separately each. So pelvic examination may I have multiple things that I'll be checking. First of all, I'm going to check for pelvic floor integrity and tone. So basically, I'm going to check for pelvic floor, my per-vaginal examination. That is something that I'll be talking about in a lecture. I've already talked about it in my pelvic organ prolapse session. I'll be checking for how strong are her pelvic floor muscles. I'll be checking the integrity. There's a pinching test that we do for the levator NI. I'll be checking how strong they are, what's their integrity. That is what I'm going to be testing. For that, there is one test that I'll be doing. That is called as the Boney's test. So what is this Boney's test? Over here, I have shown a picture of me doing a Boney's test. So over here, let me just tell you, this is your clitoris. This is my clitoris. This is my urethra. And this is my anterior vaginal wall. So what I'm doing is I've put my two fingers inside. And if this is my urethra, abhi tum log aise dekh rahe ho, I'll show you from side as well. I'm going to be inserting these two fingers and I'm going to be pressing it. First, I'm going to ask the female to cough. When she coughs, there is an increase in the abdominal pressure, there is an increased pressure on the bladder, and if the female has SUI, she's going to pass urine. But when I place these two fingers near the neck of bladder, I know that the bladder is here, and near the neck of bladder, when I'm pressing these two fingers with the tip of my fingers, I'm pressing it, this blocks the urethra over there. Then I'll ask her to sneeze or cough again. If again, after coughing, she is not having passage of urine as she did earlier, this shows that the bladder neck or the urethra is having loss of its integrity. And hence, this test tells me that if I'm going to put some suture over there or some material over there that strengthens this area of bladder neck and the urethra, it will cure her stress urinary incontinence. This test is called as the Boney's test. It is basically I'm testing whether any surgical intervention is going to help her SUI. If it fails, then I would also know that this female might rather have urge incontinence or mixed incontinence, which is basically she is also having a component of urge incontinence, and hence merely a surgery is not going to help. I will also have to treat urge incontinence. But if the involuntary passage of urine stops after I have pressed, then it indicates that a surgery for SUI is going to be helpful for her. This test, if it is done instead of using fingers by using two Allie's or Cocker's forceps, it is going to be called as a Boney's Marshall test. Nothing different, same thing using instruments. So this is my, by the way, how do I know kahan pe press karna hai? Remember that your urethra is 4 centimeters in female. So bladder neck se leke external urethral meatus tak, there is going to be a distance of 4 centimeters. So I have to press at a point of 4 centimeters from the urethra inside. That is going to be the bladder neck. Next test that I'm going to be doing is going to be a Qtip test. Now this test is obsolete now. It used to be done earlier, but because of its historical importance, I'm going to be talking about it. So this is my original bladder position that I'm highlighting right now. This is my original bladder position. इसके अंदर I have put in a swab. It is something like an elongated earbud I have put inside. Then I ask the female to sneeze. When I sneeze, this bladder is going to be sneeze or cough. This bladder is going to be pushed backwards and the urethral position also changes. So, पहले जो ये यहाँ पे swab था, अब गया है वो यहाँ पे. It has gone till here. This is going to be a physiological movement that happens in every female, and that physiological movement is usually going to be between 10 degrees to goniometer से देखना है 10 degrees to 30 degrees. This is a normal movement whenever a female is going to cough. But if this movement is more than 30 degrees, it indicates that the urethra is moving excessively and there is hypermobility of the urethra. This is also going to indicate that I need to do something so that I can strengthen the urethra, and that strengthening of the urethra will be done by either putting a mesh or a rectus sheath or some foreign body that is going to increase the caliber of my urethra. This hypermobility will need to be reduced. So an increase in the deviation by more than 30 degrees is going to be diagnostic of SUI. On the other hand, if the movement is less than 10 degree, it will indicate that there is something called as a lead pipe or stovepipe urethra. It is a higher concept. It indicates intrinsic sphincter deficiency. इसका ये मतलब है that the sphincter, the internal urethral sphincter has gotten solidified. It is not allowing any movement and the entire urethra has become too stagnated. In this scenario, a surgery for SUI may not be the best thing to be done for her, and there are other alternatives that we would want to do, but that is going to be indicative of internal sphincter deficiency. That is basically, it has become so rigid that the Qtip, that the tip, the swab is not moving at all. This is the Qtip test. So once these tests are done, the name of this test being, सबसे पहले we did the Boney's test, then we did the Qtip test. After she is done with all this, I will ask the female to go and urinate and come, and then I'll do something called as a cuff stress test. So it shows how severe is her SUI. So in a full bladder, I had already checked during the Boney's test that she is micturating. So it showed me that she has SUI. Now I have asked her to go and micturate and come back. After she has urinated, she comes back to me and I then ask her to repeat this test. If she, despite emptying of her bladder, is still passing urine when I ask her to do the cuff stress test, it is indicative of very severe SUI. So basically, her urethra has become so thin or it has become so hypermobile that not even little amount of urine that stays inside after voiding is going to be kept inside. It is letting even that much of urine outside. Basically, whenever you are about to micturate, you have a urine quantity of around 250-300 ml in your bladder. After you have micturated, a urine of somewhat around 40-50 ml is going to be normally left back in your bladder, which is normal. Even in a 40-50 ml capacity that is left, that urine that is left behind physiologically, if she's still passing urine during the cuff stress test, it just shows that how bad her SUI is. So this cuff stress test is going to only tell me how bad or how severe is her SUI. That is going to be the last test that I do. These were all the tests that I'll be doing for SUI or for checking whether this female has SUI or not. The next set of tests are going to be for me to check how the bladder is doing, and that is going to objectively tell me whether a female's bladder is having urge incontinence or stress urinary incontinence. So the next topic is going to be bladder testing, and this bladder testing is also going to combine or is going to talk about all the urodynamic studies. So there are going to be simple tests and there are going to be complex tests. So the simple tests are going to be as simple as just keeping a bladder diary. What is a bladder diary? She has to maintain it for 2 to 3 days. Earlier it was 1 week, but now even 2 to 3 days is okay. So what's a bladder diary? Over here you can see that there is a bladder diary that I've given the picture of a bladder diary that you have over here. In this you can see that this female has to note the total amount of urine that she has voided. She has to note at what time of the day, this is 22:00, which is 10 p.m., and how much urine has she micturated. So whenever she goes to urinate, she has to urinate in the container which has a measurement of the amount of urine. She has to keep a note of every time she goes to the urine. Here you can see that she is micturating almost every 2 to 3 hourly. So every 2 to 3 hourly she is doing it. She also has to note whether she had an accidental passage of urine in her clothes or in her bed and at what time. So this female is having enuresis at 3 a.m. and 5 a.m. So she is having enuresis. I also have to write what is the fluid that I'm consuming and at what time and what quantity I'm doing it. So at 10 p.m., this female had a glass of water, which is almost equal to 250 ml. Then in the morning at 7, she had a cup of coffee with a cup of water. So in the afternoon at 12, she had 1 glass of lemonade and then later on 2 glasses of wine and 2 cups of water. So basically she has to keep a charting of her input and output both. I have to check through this whether the female is over consuming fluids. A normal person consumes around 1.5 to 2 liters of fluid in one day. So if a person is over consuming, a few people have this habit of drinking 1 liter of water before going to sleep. They feel that it helps their body. It doesn't help their body. It only overloads their bladder throughout the night. So this is going to help me know what is the exact problem. Is it that the female actually has incontinence, or is it that she is just over consuming her fluids, or she's consuming those fluids that are going to cause diuresis, like alcohol? If she's having too much of alcohol, or if she's having too much of caffeine, caffeine in coffee is going to stimulate, is going to lead to an increased chance of urge incontinence. So that is going to give me a clue whether this female is having some problem with the quantity of fluid that she's having and also the type of fluid that she's having. Apart from that, I will also know about at what time is she having, how frequently is she going, so that I can give her a specific schedule wherein I'll tell her, now you're going every 2 hourly, but I would want you to stop that and instead go every 4 hourly to pass urine. That is how I'll be training her. I'll talk about it later, but this bladder diary is going to be extremely useful for me to determine what kind of care does she require. Next, after she is done maintaining a bladder diary, I'll be doing a few simple tests and it includes my urine analysis. In urine analysis, I'm first of all going to do a routine microscopy and a culture sensitivity. A routine microscopy is going to tell me if there are proteins, if there are pus cells that are present, if there is bacteria that is present inside my urine. And on culture sensitivity, I will know which exactly the bacteria is it, because recurrent UTIs need to be treated properly. It might require a prolonged therapy. It might even require intravenous parenteral therapy. So urine analysis, very important. Apart from that, there are some pad tests that are no longer done. They were done earlier. Pad tests are basically in a female who is having nocturnal urea or enuresis, they have to wear those special pads. Those pads have a large capacity and they have to wake up in the morning and they have to weigh the pads. They have to wait at night and then they have to wait in the morning. So the difference in the weight will tell how much of urine are they passing. Now these are obsolete tests and we don't do them anymore because there is no real value of knowing kitna urine kiya hua hai. Plus it makes the female uncomfortable to wear these large pads throughout the night which are storing urine in that location itself. It would also give rise to diaper rash in these patients. So we want to avoid it. The next set of tests are going to be my urodynamic studies. These are a bit complex tests and they are not as simple as I just mentioned. So urodynamic studies may I have to do simple tests and complex tests. So in simple tests, I will have something called as a uroflowmetry. I will have post-void residual volume, and lastly, filling cystometry. In complex urodynamic studies, those are going to be advanced urodynamic studies. So first talking about the simple tests, the simple urodynamic studies. So in a uroflowmetry, I'm going to show you a picture of uroflowmetry. You see over here, this is a picture of uroflowmetry that has been given. So in this uroflowmetry, you can see that this female is sitting on a special type of commode. It's more like a table, a stool on which she's sitting. But you see that this commode is more like a funnel. And this funnel is connected to some machine over here. And this wiring is given over here. Now what this does is, whenever this female is going to urinate, you can even see this male that is who is doing the same thing in this funnel-like thing and this machine below. So what this does is, whenever you start urinating, it measures multiple aspects of it. What are the multiple aspects that are going to be measured when I'm doing this? Those multiple aspects include, in a uroflowmetry, I'm just writing it as UFM. First of all, it is going to measure total kitna urine मैंने void किया है. So total urine is going to be calculated. Next, I'm going to calculate what was the average flow rate. The urine का कितना ml per second का flow था. So what was the average of the entire duration? So average flow rate of urine. I would also calculate what was the peak, what was the maximum flow rate that was achieved during urination. So peak flow rate of urine Next, I'm also going to check what was the total time that was required to void the entire urine. Total time to void entire or entirety of urine. So these are the four aspects that are going to be measured by my uroflowmetry. How does this help? The total amount of urine is going to be reduced in a patient who has urge incontinence. Why? Because this female is going to keep on going to her washroom again and again, and the total amount of urine that accumulates in her bladder is eventually going to be very less. So in every visit, every 1 hour she goes, but she voids thoda quantity. So the total bladder capacity, because of the hyperreactivity of the detrusor, is going to be reduced. So the total urine capacity that is voided is going to be reduced in a patient with urge incontinence. When do I ask them to maturate? I ask them to drink water, and then they have to come and void when they get a strong desire that मेरे को अभी urine pass करना ही है. So that total voided urine is going to be less in patients with urge incontinence. In patients who have average flow rate of urine that is reduced. So in which patients is the average flow rate going to be reduced, and in which patient is the peak rate? ये दोनों कम किस में होने वाले हैं? In patients who have some problem with voiding. Who are those patients? In patients जिनका जो bladder का normal capacity था वो बहुत बड़ा हो गया है, and all those nerve fibers are dead initially. So overfill incontinence में the bladder is not able to sense that there is so much of urine inside. That is why their urine flow is going to be very slow. Plus, in patients who have some mass of the bladder of neck, it can be some cancer of the bladder, it can be some cancer of the urethra, or it can merely be a cervical fibroid which is blocking the urethra and the bladder neck. Whenever there is a blockade in the urethra or the bladder neck, at that point of time, there is going to be problem in the voiding, and hence the flow rate, the total amount of ml per second is going to be less. So this female is going to slowly maturate. So in patients with voiding dysfunction is basically when a female is not able to smoothly urinate, and it is taking a long time for her. And hence this also answers that it is going to be increased in a patient with voiding dysfunction. So with any blockage of the bladder of neck, this can also happen in a patient who has been operated for SUI. मैंने कोई तो mesh डाल दिया है वहां पे bladder neck के इधर और वो गलती से बहुत ज्यादा tight हो गया है. It was supposed to correct the hypermobility, but it has by mistake overcorrected it, and now the instead of excessive urine, अभी बिल्कुल भी urine pass नहीं हो रहा है और वो female को urine pass करने में तकलीफ आ रही है. That is what is also called as voiding dysfunction, which is a complication of SUI surgery. So how does this graph look like of uroflowmetry? So when I look at this, you see that there is a normal graph that this is given. ये जो ऊपर है, this is the volume of urine. V is volume, Q is the curve, the rate. So you see that initially, at the beginning, the urine volume slowly started increasing, and finally, this is the total amount of urine that is voided. This is the total amount, or total capacity quantity of urine that is voided. Here, this is the flow rate. So initially the flow rate is small, then it reaches a peak and then it falls down. So whenever you urinate, you would even be able to relate that whenever you start maturating, the flow gradually increases. Then at some point it reaches a peak when you realize that it is going at the rapidest possible rate. And then finally towards the end, it again tapers down. This is a bell-shaped curve. A bell-shaped curve with only one peak. And this is how it should normally be. This is exactly how a normal uroflowmetry is going to look like. Whereas in a patient over here, you can see, in this patient, you can see that the voided urine पहले बहुत जल्दी हो गया था, but in this female, remember, उस female में urine का जो quantity था void किया हुआ was just 100 ml. You see, this was just 100 ml that was voided. In this female, it is around 400 to कितना ये 450 ml है. So first of all, this female has an over accumulation of urine in her body. So total volume जो है वो बहुत ज़्यादा है. Secondly, it is not a curve. It's not a bell-shaped curve. It has multiple peaks. पहला peak आया, फिर दूसरा peak आया, फिर तीसरा आया. Plus जो normally ऐसा होना चाहिए था, इसको बहुत ज़्यादा instead time लग रहा है. So there is increase in total time taken to void. There is also increased peaks. These peaks are because the female can feel that she is not able to void smoothly, and she is manually, forcibly trying to void. She's trying to increase the pressure so that the urine keeps on falling out. And every time she presses upon body, she just tries to force that urine out. One more peak comes. So this is going to lead to this kind of a flow, and this is very classical of voiding dysfunction or overfill incontinence, wherein the bladder is accumulating a lot of urine. Why? Because there is some obstruction at the level of bladder neck or in the urethra, जिसके वजह से फीमेल के ब्लैडर में बहुत यूरिन है, प्लस whenever she is passing the urine वो easily flow नहीं हो रहा है, so she is trying multiple times, तो बीच में फ्लो गिरता है, फिर से बढ़ता है, फिर से बढ़ता है, and this entire process which should usually take just 1 minute, this female has taken, if you see the total time यहाँ से लेके यहाँ तक, she has almost taken 1.5 minutes to void. Whereas यहाँ पे, if you see, she just took around just 12 seconds to void it entirely. So what took already 12-15 seconds earlier, for this female it is taking around a minute and a half to void, which is quite long. It is quite much more than normal. So this is an example of voiding dysfunction. So this is a uroflowmetry wherein I'm measuring the urine as it flows into that machine. It's a cup, उसके अंदर यूरिन गिरता है, नीचे एक मशीन है, वो मशीन में एक सर्कुलर मोटर घूमती रहती है, and that motor is going to calculate the total amount of urine, the total flow rate, and everything that I've just shown you. So this is a simple urodynamic study called as a uroflowmetry. Now, once this female has done voiding, I will call her to myself again after she's done voiding inside this cup, inside a special commode that we have made. After that, I'll call her back, and then either I send her to an ultrasound that is there available with me, or I'll insert a catheter. The point of this is that एक catheter और ये पास करने से मुझे देखना है after micturating कितना यूरिन अंदर बच रहा है. What is the post void residual urine that is remaining inside? So post void residual urine जो normally होना चाहिए 50 ml, in these patients is going to be more than 50 or less, उससे तो कम ही होना चाहिए, is going to be more than 150 ml. So more than 150-200 ml of post void residual volume will tell me that this female has some obstruction to the neck of the bladder, and it is preventing her from voiding the urine completely. So next what I'm going to do is I'm going to measure this catheter डाल के. Remember that whenever you void and come back, your urine थोड़ा सा 30-40 ml is always going to be left back in the bladder, which is normal. But if it is more than 150-200 ml, at that point I will have to understand that there is significant post-void residual volume, and this female for some reason is having retention of urine, most likely because of some obstruction to the outflow of urine. Once she's done with that and I've completely emptied her bladder with the catheter, I will now with the same catheter restart filling it. I will fill it back again with normal saline. This is going to be called as filling cystometry. Now, filling cystometry is basically I'm reverse filling the bladder with urine, and I'm going to do some measurement of the bladder. Till now, मैं सिर्फ urethra का देख रहा था क्या क्या है और थोड़ा बहुत bladder का capacity देख रहा था. Now I want to check, यहाँ तक voiding dysfunction का clear हो गया है, वो नहीं है तो अब क्या है? I need to look the other causes of urge incontinence, that is urge and stress. So now I will start filling the bladder again. When I'm reverse filling the bladder, I have to know a few normal values. Whenever your bladder is filling, you get the first sensation of bladder filling. Only the fact that your bladder is filling, at around 50 ml, 50 to 60 ml के time पे तुम लोग को आता है कि मेरे bladder में कुछ तो भर रहा है, but you don't feel like going and urinating. But you get the first sensation or first desire to urinate at 150 ml, around 150 ml. Whereas you get a very strong desire. At this point, first sensation, you can still feel that I will still keep on working. Maybe in the next half an hour, I will go. I have to go, but I will just finish my current work and then I'll go. But at this point, when you have a strong desire, you say that I will have to drop whatever work I'm doing. I'm not going to wait anymore. I'm just going to go and urinate. That is a point when your bladder has around 250 ml of urine. Whereas your maximum bladder capacity इसके ऊपर नहीं हो सकता, and involuntarily you will end up passing urine is going to be around 400 ml. These are your normal physiological values in a normal female. All these values are going to be reduced in a female with urge incontinence. Why? Because your bladder is hypersensitive, it is hyperactive, overactive bladder. So the first sensation is going to be obtained at 30-40 ml. The first desire to urinate is going to be obtained at 100 ml. Strong desire is going to be at 150-200 ml, and the total capacity is never going to exceed 250-300 ml. So all of these are going to be reduced whenever you have urge urinary incontinence, whereas all these are going to be increased in overflow or overfill incontinence. All of these are going to be increased. So urge incontinence को diagnose करने के लिए filling cystometry में the patient themselves tell you कि अभी मुझे लग रहा है यूरिन भर रहा है, अभी मुझे लग रहा है यूरिन जाना चाहिए. No, I now have to urinate, which is strong desire. And at the final point when the urine voluntarily just comes out, is going to be the maximum capacity. All of it is going to be reduced in urge urinary incontinence. And this simple test is called as, where you do not need any machinery, only reverse bladder filling is required. That is called as filling cystometry. At any point, if you ask the female to cough and the urine just leaks out, वो catheter के बाजू से, at that point you will say that this female has stress urinary incontinence if after coughing or sneezing she leaks while doing the test, then she is going to be called as one having stress urinary incontinence. So filling cystometry is going to help me with the diagnosis of urge, overflow, as well as SUI. Next topic is going to be complex uroflowmetry. But before that, if you have any doubts, please in the comments ask me, I'll solve it immediately. So now that we have spoken about all the simple tests and also the simple form of urodynamic studies, we have all known that these tests do give me an idea about whether it is stress urinary incontinence or urge incontinence or overfill incontinence. But I need something that is a lot more objective and is going to give me a much better idea about what is the pressure that is being created inside the bladder. Is it actually the detrusor overactivity, or what is actually the cause of that incontinence? For that, we have something that we call as a complex urodynamic study. So what is this complex urodynamic study? So complex urodynamic studies may, we have to look at various pressures. So what are those various pressures? First of all, I want to look at what the detrusor pressure is. Detrusor is basically what is the pressure that is being created inside the detrusor muscle. So detrusor pressure, which we also call as a P det. Then I would want to look at the intra-bladder pressure. So what is the bladder that has been created inside the cavity of the bladder? So intra-bladder pressure. What we also call as the T vesicle. Next, I would want to look at what is the pressure that has been created inside the urethra, intra-urethral pressure, because as we have known, that whenever there is reduction in the urothelial continuity or there is a disturbance in that urothelial continuity, it becomes very much mobile. And I had mentioned that the closing pressure of the urethra reduces. So basically the urethra opens much more swiftly. The sphincter of the urethra opens up quickly and there is a loss of urine. So that pressure inside the urethra is going to be measured as well. So intraurethral pressure, which we'll be calling as P ure. And lastly, I would want to look at the abdominal pressure. By abdominal pressure, I would want to see that whenever I cough or whenever I stress, at that moment, kitna upar tak, kitna zyada badta hai mera abdominal pressure. So PABD is going to be the thing. But how do I measure all these pressures? Obviously, I cannot just look at a patient and assess how much is the pressure. Pressure is a very specific number, and for a specific number, I need a measurement probe. I need a device that will measure it for me, and for that, we place various catheters inside each and every cavity of a female. And how does that look is what I'm going to show you now. So this was the graph that we had seen earlier. Now I'm going to show you how does the, yes. So now this is how complex urodynamic study setup looks like. If you can see over here, there is something that measures the bladder pressure. This is a probe that is placed inside the bladder. The same probe also is placed inside the urethra, which measures the urethral pressure. Then to measure the abdominal pressure, I can either place the probe inside the rectum or inside the vagina, which will measure the abdominal pressure. So intra-abdominal pressure is measured by this probe. It can be placed here or in the rectum, it doesn't matter. Now from all this, I can determine what is the pressure inside this detrusor. This detrusor pressure, obviously, I cannot be inserting a probe inside the detrusor muscle because that is going to puncture the muscle and it can even lead to bleeding. It can even perforate the bladder. I do not want all those surgical injuries. So how do I calculate it? I know as a matter of fact that an addition of this abdominal pressure and this detrusor pressure is going to be my intravesical pressure. So P vesical is going to be a sum of my abdominal pressure plus the pressure created by my detrusor. So in this, I am able to measure the P vesicle and P abdomen because of these probes. So P det is going to be P abdomen minus P vesicle. And this is the formula by which I would know what is the pressure that is being created inside this detrusor muscle. So it's an indirect way of deriving detrusor pressure. So over here, you will see that this is a chart in which I have shown, first of all, a volume that I'm increasing. So you see this number that is given over here. This is the increasing volume of urine inside my bladder. So as you see that when the volume is increasing at 88 ml, there is a first increase in the P vesicle pressure, whereas there is no abdominal pressure increase. This shows that there is no stress. When does the abdominal pressure increase? Whenever there is some stressing factor like I'm coughing or I'm sneezing. But over here, there is no stressing factor. But whenever there is this urine ka increase by 88, this is of a patient that 88 can be 100 for someone, 70 can be for someone else. So whenever it is at the level of 88 for this patient, you see there is a spike in the vesicle and the detrusor pressure. Similarly, at 98, there is a bigger spike. At 102, there is another spike. This shows that as the urine is increasing, and remember, I told you that the first desire to void comes at 150 ml. यहाँ पे तो 98 102 पे ही बहुत अच्छा खासा प्रेशर बन रहा है. जब प्रेशर बनता है मुझे सेंसेशन आता है यूरिनेशन का. So this is indicative that my bladder is very active. It is overactive in fact. This is diagnostic of urge incontinence. These spikes that are occurring at less than physiological levels of urine inside my bladder, these spikes बीच में there is a contraction. थोड़ा भी bladder के अंदर urine भरते हैं तो bladder starts contracting. It just doesn't want to keep any urine inside itself. This is going to be diagnostic of urge incontinence. A very good test, a very important test, urodynamic study, complex urodynamic studies, and this is how you're going to interpret how does the urge incontinence component work. You see there are increases, there is a special spike that we can see inside the bladder and inside the detrusor muscle. And hence, I diagnose that this is a patient with urge incontinence. So, how do I diagnose SUI from this? So, SUI ke andar, you would see that whenever, I'll just erase all these things, how is it going to look in SUI? So, in SUI, this urine is not going to make much of a difference. But whenever I ask the patient to cough, let us assume that I ask the patient to cough at this point. When a person coughs, this is going to increase. This abdominal pressure is going to increase. And that very instance, the detrusor pressure is also going to increase. The P vesicle pressure is going to increase. And the volume is going to go down. Why? Because every time that female is going to cough, because of that increase in pressure, that female is ending up reducing the urine from her body. She leaks urine and hence the volume goes down. So 98 के बाद में यहाँ पे 90 पे आ जाएगा. So whenever there is an increase in abdominal pressure, it is followed by reduction in the volume of urine inside the bladder. That is how I will know whether this female has SUI or not. So voluntarily मैं abdominal pressure increase करूंगा उसको cough करा के बोलने या फिर sneeze करने and the urine just leaks out and this reduces. This is how I'll be seeing. What will happen in mixed incontinence? In mixed incontinence, I will see this as well as whenever I ask her to cough, I will see a leakage. So these two things are going to be seen in mixed incontinence, and that is how I will diagnose stress, urge, or mixed incontinence on the basis of urodynamic studies. So the next question that obviously comes to me is, do I need to do a complex urodynamic study because it is a slightly invasive procedure, putting catheters and all inside the female? It is going to be slightly painful. So is it a necessity to be done in all females? The answer is varied. Now, let me tell you that this question was asked to me in my interview for assistant professorship at KEM Hospital last year. And so the same question, they had first asked me which is a branch of my interest. And as I told you, that urogynecology is something that I love. So I told them urogynecology. So they had asked me this very question that do you do urodynamic studies for all patients who come to you with urinary incontinence? My answer to it, which actually satisfied them thankfully, and I got the job, thankfully, I'm grateful to them. My answer was textbooks say that for stress incontinence, you do not need a urodynamic study because it is merely going to be confirmed whenever you do a normal Boney's test. Whenever you do physical examination, it is going to be confirmed. For urge incontinence, whenever a female is giving me such complaint that she has urges, increased frequency, and in that patient to confirm it, I would do a urodynamic study. This is what textbooks say. They say that you do not need to do urodynamic studies for stress incontinence, but you need to do it for mixed and urge incontinence. But in reality, all the urogynecologists and urologists say that almost every female has some or the other component of stress incontinence as well, along with urge. So basically, almost all patients have mixed incontinence, but in them, mostly it is one component predominant over the other. मतलब कुछ लोग में stress का component ज़्यादा होता है than urge, whereas few patients में urge is more than stress. Just so that I do not miss out on the slightest possibility of urge incontinence, in all the patients, we do urodynamic studies whenever possible. Classically, the textbooks say no, but all the latest urologists and urogynecologists say that you should do it for all of them because when you treat the patient, if you are treating her only as a patient of SUI and you do not treat her for urge incontinence and it eventually turns out that she also had urge incontinence, then you would have partially treated her problem and she'll still come back to you with complaints of leakage of urine despite doing a surgery for SUI. Hence, it is to be done in all is what you do in practical life. According to your books and in your exams, you can just say that in SUI, you do not need to do it. In mixed and urge incontinence, you will be doing it. That is your answer. So, this is about complex and complex urodynamic studies. Are there any other tests that I need to do? Yes, you can do USG, you can do CT, you can do MRI, but then it does not carry much of a value. You can also do something called the cystoscopy, which is basically inserting a camera from the urethra into the bladder to check whether there are any lesions or not. But that is it from the diagnostic test point of view. Now we come to the most important part of our session today, and that is the management. What do I do in management? I have three modalities. First is going to be a conservative modality wherein I don't do anything. I just give her lifestyle changes. The other one is where I give her medicines, drugs. And the last resort is going to be surgery. So in conservative, first of all, I'm going to give her lifestyle modifications. When I say lifestyle modifications, they include, first of all, I'm going to tell her to stop alcohol consumption and smoking, because I've already told you that alcoholism is going to lead to, it is one of the reasons for incontinence, and smoking is going to lead to atherosclerosis. It is going to cause ischemia and increased risk of urge incontinence. Next, I'm going to tell her to start with the weight reduction, because weight reduction, obesity is going to reduce the pressure on your pelvic floor. It is going to reduce the pressure on your pudendal nerve, and it is also going to help you reduce the chances of hyperlipidemia, atherosclerosis, and eventual urge incontinence because of the ischemic injury to the detrusor. Next, I'm going to tell her to reduce her caffeine consumption. Now, remember that caffeine is going to be something that acts to its nicotinic action. Nicotinic is a receptor. Nicotine is a receptor of acetylcholine, which is in fact a parasympathetic nervous system component. So basically, it will lead to bladder contractions, and caffeine is going to increase your chances of patients having urge incontinence. It is going to worsen the urge component of it. Apart from that, I'm going to tell her to practice a few distraction techniques. Now, what are those distraction techniques? This is more so useful for a patient with urge incontinence. So when I start treating this patient, I'll just come to it on the next point because the next point is absolutely about it. The next point after lifestyle modification is going to be about bladder training. What does bladder training mean? Bladder training is more so useful for urge incontinence. What do we do? In that, I tell her that you have to take timed washroom breaks, which means that at a specific time only she will go. You do not exceed those times, you do not reduce those times. उतने ही interval के बाद जाना है. So if a female is right now going to a washroom every 1 hour, I'll tell her that अब से तू 1 hour नहीं करेगी, 1 hour 30 minutes करेगी. और फिर बोलेगा एक हफ्ते के लिए 1 hour 30 minutes का ब्रेक्स लेना है, अगले हफ्ते से you'll make it 1 hour 45 minutes. So इनिशियली if she is starting from 1 hour पहले करती थी यूरिन, मैं उसको पहले बोलूंगा कि तू 1 hour 30 minutes बेसिकली 1.5 घंटे के बाद 1 hour 30 minutes, 1 hour, which is 1.5 hours के ब्रेक पे जाएगी. Do this for 1 week. From the next week, make it 1 hour 45 minutes. This is 30, so 1.5 minutes लिख देता हूँ. Make it 1 hour 45 minutes. In the next week, make it 2 hours per 1 week. ऐसे करते करते, I would want to get her to 4 hours intervals at which I can stop doing it. So what does she have to do? She has to try to prevent the urge. She has to stop that urge from making her go and micturate. She has to try that she doesn't micturate, and because now she'll start feeling that urge, and that urge can be very disturbing. So in that, she will have to learn some distraction technique wherein she just starts listening to some songs of her own choice, or she can start whistling, or she can just focus on some other work at this point of time so that she doesn't focus too much on her urge that the bladder is giving out. Obviously, it is very difficult because that urge to micturate is a very strong urge and people are not easily able to adjust to it, which is why bladder training is often done along with medical management. We give them drugs as well as we tell them to do this bladder training simultaneously so that the urge is not that strong enough that she ends up leaking, voiding in her clothes itself. Washroom में गई लेकिन clothes में ही हो गया. To prevent all these things, we also give them simultaneously medicines. Apart from that, in conservative management, I also have devices that I can use. Devices includes special pessaries. So a normal pessary, as you have seen, looks like this. A normal pessary जो होता है वो ऐसे दिखता है, that you use for pelvic organ prolapse. जो इसका pessary होता है SUI का, उसको एक ऐसे यहाँ पे bulge होता है. So what it does is when you insert it inside, this stays anteriorly, this goes posteriorly. When you insert it inside the vagina, this bulge over here is going to block the urethra. You put it inside with this part being anterior, तो यहाँ पे जो आगे urethra जाएगा, उसको वो block करेगा and will prevent the female from passing urine. This is very useful for patients with SUI, जिनमें there is bladder neck का weakness, there is urethral hypermobility. So this blocks the internal urethral sphincter with that bulge, and every time a female wants to micturate, she just has to remove that pessary and then she can go and micturate. This will prevent the component of SUI. Whenever she coughs or whenever she sneezes, the escape of urine is going to be prevented. So specialized pessaries can be used that press and close the urethra forcefully. The next management is going to be medical management. Medical management is mostly useful only for urge incontinence, not for stress urinary incontinence. Why? Because stress incontinence is more to do with anatomical problem that the female has, the urethral hypermobility, the pelvic floor weakness, whereas urge incontinence has a lot to do with the parasympathetic and sympathetic nervous system imbalance. Basically, there is hyperexcitability of the bladder tissue. So I can still correct it with medication, but for SUI, I will definitely require something that strengthens the bladder neck or the pelvic floor, which is where surgeries are only going to help in SUI. But in urge incontinence, I have various options. So what is my motive of doing a medical management? My motive is going to be that I want to reduce the increased bladder contractions that are occurring. So I would want to reduce the bladder tone. And can also call it the bladder contractions or involuntary contractions, or I want to reduce that. How do I reduce it? So I have two ways. I can either reduce the parasympathetic nervous system or I can increase the sympathetic nervous system flow. How do I reduce parasympathetic nervous system? Of course, you remember that sympathetic nervous system का काम ही है to lead to bladder filling. So if I increase the sympathetic nervous system flow, it is going to lead to bladder filling. Whereas reducing parasympathetic nervous system is going to reduce the chances of her voiding. So it is going to be a blockage of my parasympathetic nervous system. How do I block it? I have drugs called as anticholinergic drugs. Anticholinergic drugs are going to block the acetylcholine receptors. They can either be non-specific or they can be specific. When I say specific, specific to the muscarinic receptors, M2 receptors to be more specific. So in the non-specific part, I'll just erase this, Jacob. Yeah. So in the non-specific receptors, they used to be the older drugs that we used to use, which included oxybutynin, tolterodine, trospium chloride, all these drugs. Now the problem with these drugs were that it was not specific and it had systemic side effects. The systemic side effects included, सबसे पहले तो remember acetylcholine is a neurotransmitter, so it led to blockage of neurotransmission that led to loss of memory and dementia. Not just dementia, it also led to an increase and early onset of Alzheimer's disease. So CNS ke side effects were very significant. The person became forgetful. Next, the patient complained of constipation. Why? Because your anticholinergic are going to block peristalsis. They are going to slow down peristalsis. They are also going to block all your mucosal secretion of all the serum, of all the mucus and everything in the bowel. So that is going to lead to hard stools that are accumulating in the bowel loops for too long, that leads to constipation. There are going to be dry side effects. What are dry side effects? There are going to be dry eyes, reduced salivation, dry nose, all these things. Apart from that, it can also lead to glaucoma. Closed angle glaucoma, as you have read it, it will lead to glaucoma, which is going to result into blurring of vision and even pain. So these are side effects that are absolutely unacceptable and going to spoil the patient's life completely. So we had an alternative that was not completely non-specific, and we had M2 receptor antagonists. The name was solifenacin and darifenacin. These two drugs had very low side effects. The biggest benefit of them was that they were not crossing the CNS and they were not leading to loss of cognition, loss of memory and dementia, and hence solifenacin, darifenacin are drugs that are actively given even today. The other option was I completely skipped this and I instead give something that is going to increase the sympathetic nervous system, which is basically a beta-3 mimetic. Now, beta-3 receptors are exclusively found only in the bladder, and the drug that we gave for that was mirabegron. Mirabegron is a wonderful drug and it can be given to all patients. There is only one problem, that beta mimetics, they are all contraindicated in patients with hypertension and in patients with heart disease, and hence many of our patients who are going to have urge incontinence are patients who are above the age of 50, as we have already spoken. So they might end up having heart disease, history of some heart disease, hypertension or diabetes. So in them, I cannot give mirabegron. So it is only to be a drug to be given if a patient does not have any heart disease or vascular disease. And otherwise, it's a very good drug that can be given. So mirabegron is a beta-3 mimetic. Remember that. It's the only drug in that class. Next, my alternatives were going to be if none of them is getting cured, if my urge incontinence was leading to enuresis and nocturnal urea. In that scenario, I would want something to stop the production of urine at night. How do I stop the production of urine? I increase my body ka anti-diuretic hormone. So I use anti-diuretic hormone analog. Anti-diuretic hormone का दूसरा नाम है vasopressin. Vasopressin का analog का नाम है desmopressin. Desmopressin reduces the urine production by itself and it will reduce the episodes of nighttime enuresis and nocturia. Apart from that, we also have tricyclic antidepressants like imipramine, which also reduce the urine production. But again, imipramine is going to have anticholinergic action and systemic side effects are going to be plenty. So this is something that I can do. Next, if I have to give any medical management for SUI, I've already spoken, there is no management. The other thing that I can do is for overfill incontinence, wherein the bladder is getting filled completely and it is not able to contract. In that scenario, I rather want to increase the treatment for overfill incontinence. Is going to be to increase bladder tone because the bladder is lying all flabby. So how do I increase the bladder tone? I give something that increases the acetylcholine. The drug name is bithanecholine. What I can also do is I can open up the urethra by reducing the urethral tone. How do I reduce the urethral tone? I give an alpha 2 blocker. Alpha is a constricting, alpha 2 receptor is something that constricts the internal urethral sphincter. I would want to give something that releases that. So a blocker called as alfuzosin. Okay. Now finally coming to the surgical part of management. Surgical part mein I have urge ka management, yes, if medical management has failed, and stress ka management, stress urinary incontinence ka management. So when do I use urge incontinence के लिए surgery? So whenever my medical management has failed at that point of time, I'm going to be using. Okay, yeah, we are back. So whenever we have medical management that has failed, in that scenario, we go for surgical management. So surgical management is going to be different for urge incontinence and for stress incontinence. For urge incontinence, the surgical management is going to be, there are various ways in which I can do it. The first is going to be Botox injections. The second is going to be percutaneous tibial nerve stimulation. And lastly, it is going to be sacral neuromodulation. Now, Botox injection. Botox, we have red botulinum toxin in cosmetics and dermatology. Toxin. It is an anticholinergic agent, and the drug that we use is botulinum A. इसको short में ONAB बोलते हैं. So in this, what we do is, as you can see, that cystoscopically, I have introduced a probe from the urethra. This is a probe that I have introduced into the bladder. And at 20 various points, these dots that you can see, at 20 points, I am going to inject 100 units of botulinum A. What this does is this way, I'm going to insert it like this. This is the lateral view, and inside the detrusor, this is my detrusor muscle. Inside the detrusor, I'm going to inject this. What this does is it blocks the acetylcholine receptors. Once they are blocked, they stay blocked for 6 months to 12 months. And at various locations, 20 in total. So basically, I'm stopping the bladder from contracting totally. The problem this will lead to is that the female will not even be able to void when she wants to. We stopped her involuntary leakage, but अभी उसको बिल्कुल भी contract ना होने के वजह से, it is going to lead to complete overfilling of the bladder, and hence these patients often have to do, or they have to learn, intermittent self catheterization, which is basically they have to learn to catheterize themselves whenever they want to maturate. So they intermittently catheterize themselves, the urine flows up and they remove the catheter. They do not have a catheter stuck to them like a Foley is inside them permanently. They put it inside whenever they want, every 2 to 4 hourly. They empty the bladder and they resume their work. So intermittent bladder catheterization is going to be important. Now this botulinum toxin is a toxin, and for every toxin there is going to be an antibody that the body is going to make, because it's a foreign thing that is coming inside. So over a period of time, because antibodies start developing against this botulinum A, the effectivity of this injection reduces. So initially, what required treatment every 6 months to 1 year, eventually it becomes 3 months to 6 months, later on monthly. So over a period of time, there might be a need to do this procedure every month. So the problem of this is going to be, first of all, bladder voiding dysfunction. Basically, the bladder is getting completely filled up, it is not able to contract. And secondly, the increased frequency of repeated injections over a period of time because of the development of antibodies against the botulinum toxin. But that is how we do Botox injections inside the bladder. The next technique is going to be percutaneous tibial nerve stimulation. Now, you have to know that parasympathetic nervous system is controlled by S2 to S3. S2 to S3, S2 to S4, which happened to be the pudendal nerve. That is what was your parasympathetic nervous system for main supply. Now this segment is going to be connected by the tibial nerve. This tibial nerve which lies on the medial side of the foot, वहां से लेके it is going to connect. तो इसका L4 से लेके S3 तक nerve roots है of tibial nerve. So what they do is they stimulate this tibial nerve with a machine just above the medial malleolus. It sends a signals to the S3 S2 वाला segment. यहाँ पे वो signals भेजता है and that modulates or that inhibits those nerves. Once that is inhibited, my parasympathetic nervous system is going to inhibited. Inhibition of parasympathetic nervous system is going to reduce the urge to maturate. So that is how this is going to indirectly work. The other option is to directly act on these sacral nerves by putting in a pacemaker-like device inside the buttocks over the iliac crest. What this does is it directly stimulates and stops the nerve supply to S2 and S3 and S4, which will block the pudendal nerve, which will block the parasympathetic nervous system. This is called as sacral neuromodulation. Basically, I'm controlling the sacral nerves. It's a very invasive procedure and very expensive, rarely done. If none of this works, I have only one thing that I can do. We have already spoken that in urge incontinence, the total bladder volume is going to be reduced. So I would do a surgery that will increase the bladder volume, and hence the last resort for urge incontinence is going to be augmentation cystoplasty. What is this? I increase the bladder size from this to this. How do I increase it? I add some other surrounding tissue. Mostly we add the ileum to the bladder and make it into one. So we connect the ileum to this so that the complete bladder volume is going to increase. So this is called as augmentation, which is increasing. Cystoplasty is repairing the bladder. Augmentation cystoplasty is the last resort for urge incontinence. But remember, now that I'm connecting the ileum, all the fecal content is going to come to the bladder and that can lead to increased chances of UTI, which is not going to be a great thing. Last and the most important part of the session is going to be surgeries for SUI. Now, when I talk about surgeries for SUI, the principle of all my surgeries is going to be to reduce the urethral hypermobility. So I have to reduce the urethral hypermobility and I have to increase the urethral integrity. जो लॉस ऑफ इंटीग्रिटी हुआ था हमने इंट्रिंसिक और इंटीग्रल hypothesis or theory में पढ़ा था. I have to increase it. So these are my two main goals. So what are the various surgeries that I have? What are the various options that I have? The first one is going to be pubovaginal sling surgery. Pubovaginal sling. Next is going to be anterior colporrhaphy, or what we also call as the A repair, that we do along with vaginal hysterectomy. So anterior colporrhaphy with Kelly's plication. I'm going to discuss all of them. Next is going to be needle suspension surgery. And then I have retropubic colpo suspension surgery. And lastly, the most important one in today's day and age, mid-urethral sling surgery. So in this, the ones that are done today most commonly include retropubic colpo suspension surgery and mid-urethral sling. These are the two most important surgeries with the highest success rate that are done. Starting with the pubovaginal sling surgery, I'll do it with the images over it. So now this is an image wherein I have shown how does this work. Now you can see over here, this is a patient who is lying down to give you an overview of the anatomy. This is the anterior, this is the posterior, this is the head ka side, and this is the feet ka side. So I can even call this superior and inferior. This is the anterior abdominal wall. This is the subcutaneous fat that is there over here. This is my urinary bladder. This is my uterus. This is my rectum. This is my pubic symphysis over here. In this picture, you can see how I have put up this sling around the bladder neck, and I've pulled it out from here above the pubic symphysis on the abdominal wall. So what we do in this surgery is, in a pubovaginal sling surgery, first of all, I need to determine where do I make this sling from. So that sling can be made from autologous, मतलब मेरी खुद के body से मैं बना सकता हूँ. Autologous sling हो सकता है, or it can be a donor autograft, which is actually from the same species, मतलब from a cadaver from another person, or it can be from other species like porcine or from bovine, which is cow, or from a pig. Other species, or lastly, it can be synthetic like a mesh. So autologous may I have two options. First is I can take my own rectus sheath, or I can take my fascia lata from my tibial tract. So what we do is, you have your abdomen, you take a lower segment cesarean section wala incision, phalansteal incision, and you take a bit of the rectus sheath, you cut it out, you cut out a part from it, and then you use it over here. Or you can even cut out a same piece, a length, lamba length wala piece from your fascia lata, from your lateral tibial tract on your thighs. Then you make an abdominal incision and you place this inside. Yeah. So what you do is, now you are looking this from the abdomen. You see this image? You're looking at it from the abdomen. This is my rectus muscle over here. This is that sling that I have inserted. Yahan pe. And this is my urethra. And this happens to be my bladder neck. This is my vagina over here. This is my urethra. So what I've done is, from the abdomen, I have inserted this. I have put it behind the urethra and I've pulled it upwards like this. I have pulled it outside onto the abdomen. So what it has done is, it has formed a sling near the bladder neck. So pubovaginal sling is going to strengthen the bladder neck, the same bladder neck जहाँ पे मेरा internal urethral sphincter हुआ करता था. So this artificial tissue is going to strengthen the weakened urethra by placing that tissue around it. And finally, at this point, I'm going to tie a suture on the rectus muscle and the rectus sheath anteriorly. So basically, I'm going to tightly fix it. So once I've fixed it, it cannot get loose. And this actually became the pitfall of this surgery, that because it was being fixed, if it became a little too tight, the female was not able to void at all. She was not able to pass urine at all. And that led to its biggest side effect or the complication of the surgery, and that was called as voiding dysfunction. So basically, a female who was passing urine every time she coughed, now she cannot pass her urine at all because this urethra just got blocked. But this was a surgery that took place for a long period of time, and a few people have started doing it again, and they're just doing one more modification, that they're not tying it over here, they're leaving it loosely. But the main point over here is that the bladder neck is going to be the one that is going to be tightened by this sling. The next surgery that we had was the anterior colporrhaphy, or the A repair that we do in a vaginal hysterectomy. Anterior colporrhaphy. Colpo is the vagina, raphy is repair. So what we do in this is my anterior vaginal wall. I've taken an incision on this and I've cut open with a scissor. Once I've cut open, you can see that there is the endopelvic fascia that is present over here, what we also call as the pubocervical fascia. This pubocervical fascia, you see, ऐसे हमने इसको टाइट कर दिया सूचर्स लेके. We tightened it up by taking these sutures like this. By doing that, I'll just show you an example. This is my pubic symphysis. This is a sagittal view. This is my sacrum. This was my bladder with my urethra, and this was my uterus with my vagina. इन दोनों के बीच में हुआ करता था ये एंडोपेल्विक फेशिया. इट इज देयर एवरीवेयर इन द पेल्विस. सो व्हाट आई डिड वाज, ये हो गया था थोड़ा सा लूज. This had become thoda loose at various points. So what I did was I pulled up जो भी बचे हुए यहाँ के fibers थे endopelvic fascia के, and I brought them together and I tied them. This strengthened the support that was there behind the urethra and the vaginal wall. This brought them closer and it tightened the support, and hence this worked on the hammock theory. It basically helped to strengthen the anterior vaginal wall and provide a firm support. You see, यहाँ पे firm support बन गया है, and then we would leave it behind. One more thing that we would do यहाँ पे was I would take a stitch near the bladder neck into the endopelvic fascia and the anterior vaginal wall. This stitch was called as Kelly's plication. This also helped to address the weakening of the bladder neck as we were doing in the pubovaginal sling. So endopelvic fascia को मैंने tight कर दिया, compact कर दिया, and यहाँ पे एक stitch ले लिया. This was known as anterior colporrhaphy with Kelly's plication. But the problem was that these patients were postmenopausal women in whom the endopelvic fascia was anyway very less, as I've mentioned earlier, that it is dependent on estrogen. So because of this thinning, first of all, the endopelvic fascia was very less, and even if you tried to repair it after a few years, because of the lack of estrogen, it would again spread apart and the surgery would fail. Secondly, that suture material would over a period of time get loose, and hence the Kelly's plication would fail as well, and hence Kelly's plication is said to have a success rate of only 40%, which is like 60% patients are going to have a recurrence of this complaint. Worse, if this Kelly's stitch became too tight, it would lead to a complete blockage of the neck of the bladder, and that would lead to voiding dysfunction. Again, the patient couldn't void at all, and hence a side effect, a major side effect of this surgery or of this Kelly's plication was that blockage of the urine ka outflow. Hence, this surgery is no longer done much because of its high recurrence and failure rates. Then we came to the arguably the best surgeries that we have today in the market for this procedure, and they happen to be the retropubic colposuspension surgeries. What does the name say? Retropubic is behind the pubic symphysis, as you can see over here. Colposuspension is suspending the vagina. I will first show you a bit of anatomy. So in this anatomy, I'm going to show you a bit of anatomy of the pelvis so that you can relate better to the anatomy before I talk about these two surgeries. Now over here, you can see that this is a bony pelvis. In this bony pelvis, you can see that there are multiple ligaments, but the most important structure that I would want you all to see is first of all this. I'll make a red pen. Is this sabse pehle? This is my pubic symphysis. Secondly, is this structure that you can see over here. This is my Cooper's ligament. These two structures are very important whenever I'm talking about the surgery of retropubic colposuspension. Why retropubic? Because all these surgeries are going to be done behind the pubic symphysis. I'm going to suspend the vagina to structures behind this pubic symphysis. So now if I'm going to put back all the tissues inside it, you can see yahan pe, this is going to be my bladder. This is my urethra. This is my bladder. At this side is my Cooper's ligament, as you can see. This is my Cooper's ligament. Also over here, this is my pubic symphysis. So what I'm going to do is, and this of course is my anterior vaginal wall. Yahan pe, ye piche anterior vaginal wall hai, and this is the endopelvic fascia that I was just talking about. It lies on it. This white thing is the endopelvic fascia. Uske piche hai mera vaginal wall. So what I'm going to do is, I'm going to pull the vagina and this endopelvic tissue, and I'm going to suture it with this. This process of doing this stitching behind the pubis is actually retropubic colposuspension. I can either attach it to the periosteum of the pubic bone, or I can pull this and attach it to the Cooper's ligament. So what are my options in this retropubic colposuspension surgery? Retropubic colposuspension surgery. I can either attach it to the periosteum of pubic symphysis, or I can attach it to the Cooper's ligament, or I can just attach it to the obturator fascia. When I do it behind the periosteum of the pubic symphysis, that surgery is called as the MMK procedure. MMK procedure stands for Marshall, Marchetti, Krantz procedure. What this is doing is, it is pulling the urethra towards the pubic symphysis and is giving a support to the neck of the bladder at the beginning point of the urethra. So if this was my bladder and if this was my urethra, by putting a sling आगे की तरफ से, sling as in ये जो colposuspension जो मैं कर रहा हूँ, I'm pulling the vagina आगे. This is going to pull the urethra as well आगे, and it is going to strengthen, it is going to increase the closing pressure of that urethra. So this urethra is now going to be tugged towards the pubic symphysis, and this anterior pulling is going to strengthen it. It is going to give it support. I'm going to use the vagina and the endopelvic tissue to pull it and give it support, and hence it is again based on the theory of strengthening the hammocks theory जो है, जो hammock जैसे काम करता है vagina, उसको मैं आगे खींच के उसको strengthen कर रहा हूँ. This procedure is Marshall-Marchetti-Krantz. The same thing, if I do it slightly laterally onto the Cooper's ligament, it is going to be called as Birch colposuspension. Whereas for obturator fascia, there is no specific name. So I'm now going to show you a few pictures. How do we do it? So you see, यहाँ पे इन्होंने दिया हुआ है कैसे हम कर रहे हैं ये प्रोसीजर. So there are various surgeries जो B नाम दिया है. It is the pubic symphysis जिसके पीछे हम लग रहे हैं. That is my MMK procedure. I can go and attach it to the Cooper's ligament. ये C जो दिया है, which is called as the Birch colposuspension. I can do it laterally जो D दिया है, which is obturator fascia as well. A जो है, that is called as paravaginal repair, जो arcus tendinous पे हम लोग tighten करेंगे. What we do is mostly Birch followed by MMK. MMK का problem ऐसा है, when I'm taking sutures on the periosteum, it can lead to periostitis pubis, which is why we don't prefer to do that. We do Birch colposuspension. So over here you can see that this was my urethra. Over here, this was my urethra. इसके बाजू में ये vaginal tissue से मैंने sutures लिए हुए हैं. You can see there are multiple sutures, anchoring sutures that have been taken over here. And on this Cooper's ligament laterally, we have put those sutures through them. And now I'm going to tie them anteriorly so that this urethra is going to be pulled forwards and is going to be afforded better closing pressure. It is going to be tightened, and hence that is going to prevent my stress urinary incontinence from occurring. So even if I'm going to sneeze or I'm going to cough, the urethra is going to be tightly bound to these ligaments, to these structures that will prevent the escape of the urine. Obviously, I do not want this procedure to fail. Hence, I will be using permanent sutures and not absorbable sutures like Prolene or Boratex. These are the permanent sutures that I use because I do not want this surgery to fail. The sutures should stay in that place for her lifelong duration. This is how we do retropubic colposuspension surgeries. And lastly, we come to the last topic of the day, that happens to be my mid-urethral slings. Mid-urethral slings address the most important issue, that was voiding dysfunction because of the bladder neck obstruction. All these surgeries that we did until now, they were blocking the neck of the bladder. They were tugging the neck of the bladder. So mid-urethral sling surgery वालों ने बोला कि we will do a procedure which will not block the neck of the bladder, and it is going to be at the mid level of the urethra. तो 4 सेंटीमीटर है, तो बीच के जो 2 सेंटीमीटर है उसमें रहने वाला है हमारे ये sling. For this procedure, they also said that the problem with pubovaginal sling was that they used to tie the suture. the tying of that suture will make it very tight. So this procedure is going to be tension free because we will just leave the mesh over there. We will not tie it anywhere with tension free, sorry. We will not tie it anywhere. They decided to use this polypropylene mesh. This is the mesh. This is how that mesh looks like. ये जो mesh है, इसके अंदर की जो जाली है, all these spaces help in the growth of fibroblasts. So इनका plan ये था, once you place this mesh inside, there will be fibrosis along this entire mesh, and that fibrosis is going to help provide a permanent support for that urethra behind it. So it will form a fibrotic band that will improve the integrity. Remember, I had said that there is increased hypermobility and also reduced integrity because of the urothelium that is damaged. This is going to form that fibrotic band around the urethra, which will ensure that the thinned out urethra is now again thick enough. What are the surgeries that I had? The surgeries that I had were two, either a TVT or TOT. TVT was tension-free vaginal tape, and TOT was transobturator tape. In tension-free vaginal tape, the procedure was done in this way. First of all, I had to take an incision on the vaginal skin. From the vagina, I had to take an incision. Here you can see, यहाँ पे, there is a vaginal incision that has been taken. This incision over here. It's a small 2 centimeter incision that is taken on the vagina. From that incision, I have introduced a stylese or a thin scissor and I'm going to dissect the area lateral to it. इसको एलिस फॉर्सेप्स से पकड़ के जो यूरेथ्रा है उसके दोनों साइड पे मैं एक ट्रैक्ट बनाने वाला हूँ using a scissor. Once that tract is made, then I am going to introduce inside the bladder this Foley's catheter along with a guide wire. Guide wire Q. This guide wire is going to help me push the bladder on one side. Then I'm going to put this trocar from this incision that I've taken and I'm going to pass it upwards towards the abdomen. So what I'm doing is, if this was my urethra and if this was my bladder, मैंने एक mesh को यहाँ से ऐसा डाल के abdomen से निकाला हुआ है. This was my mesh ऐसे, वो मैंने mesh ऐसे डाल के abdomen से निकाल दिया at the mid urethral point से मैंने निकाल के ऊपर से निकाला. So this is a trocar जहाँ से मैंने push किया है ये mesh ऊपर. So once I'm done doing that, this is how the final outcome is going to look like. You see, this is the urethra over here. This was my urinary bladder. And this is the tape that has come, and just use a black color for that tape. And this is the tape that has gone beyond the urethra at its mid-level and come out through the abdomen through 2 small incisions. Now the thing that we are doing here is, this is tension-free vaginal tape, so we are not putting any suture at this point, we are just leaving it open. And ये vagina से ऊपर आने वाला है. Now because we have inserted this mesh from below upwards, we call this as the bottoms-up technique. Wherein I'm pushing that mesh from the vagina upwards. How do we push it? यहाँ पे उन्होंने दिया हुआ है. पहले एक साइड से मैंने डाला ऊपर, फिर मैंने दूसरे साइड से डाला ऊपर. ये दोनों टाइम पे अगर मैं इस साइड से डाल रहा हूँ तो ब्लैडर को मैं इस साइड मूव करूंगा. अगर इस साइड पे डाल रहा हूँ, then I'm going to move the bladder to this side so that I avoid injury to the bladder. In this, I mobilize the space behind the pubic symphysis. I go through the space of Retzius. There is a space of Retzius that is present over here. So this is going to be passed retropubically. So we also call that as a retropubic mesh repair. Because below the pubic symphysis through the space of Retzius, I'm going to pass this anteriorly and bring it from an abdomen. So I require only 2 incisions. एक है मेरे वजाना में छोटा सा और एक है abdomen में दोनों साइड पे जहां से मैं वो ऊपर निकालूंगा. And that is how tension-free vaginal tape is placed in situ. That is how TVT is done. This is how it is going to look from the abdomen. This is my urethra over here. This was my bladder over here. And this is the mesh that has come out from the abdomen. Obviously, I'm not opening the abdomen. This is just an example to show you all. This is how a TVT procedure will look from the abdomen. And I'm going to leave it freely there so that it forms a tract and I don't even lead to voiding dysfunction. The next procedure is going to be TOT, transobturator tape. This is something that we do much more often in my institute. What we do is, this is my groin fold. This is my adductor longus, as you can see. And over here, I can see a few structures. So this is my clitoris, this is my urethra, and this is my vagina, this is my rectum. What I do is just 1 centimeter lateral to the groin fold, I find a point on a line that is with the clitoris. So clitoris के line में एक line ढूंढता हूं मैं 1 centimeter apart. From this 1 centimeter apart, I insert this instrument, what we also call as a TOT needle. ये TOT needle, you see, ये है मेरा और ये है मेरा clitoris. So उसके 1 centimeter के distance पे from the groin fold, I introduce it inside, and with my finger, I bring it out from my vagina. You see, ये मैंने कैसे अंदर से डाल के बाहर निकाला. Now this has passed through the obturator foramen, through the obturator fascia. I do it on both sides. This is going to pass it from here. दूसरे साइड से भी मैं सिमिलरली करूंगा, यहां से भी मैं डालूंगा और निकालूंगा, एंड दिस mesh is going to look like this. So ये यूरेथ्रा है और ये mesh ऐसे दिखेगा दोनों साइड से जब मैं करूंगा. You see, ये साइड से भी किया है, वो साइड से भी मैंने किया हुआ है. Now this mesh is going to lie freely below the urethra and is going to form a tract that will lead to strengthening of the urethra. I have to ensure कि मैं यहाँ पे इतना space छोड़ रहा हूँ so that the bladder neck is not obstructed. We usually pass in a number 9 agar to ensure that it is not getting blocked. तो इतने area मुझे छोड़ना है empty so that the urethra is not completely obliterated. And this is going to be brought out from the skin, and I can just cut the ends apart. I do not have to tie it. This technique is called as the outside in technique, because मैंने बाहर से needle को अंदर भेजा है. We also have the inside out technique like this, जो मैं अंदर से डाल के बाहर से निकाल सकता हूँ. Inside out technique. It is based on the comfort of the surgeon. The advantage of doing this transobturator repair over transvaginal repair or transvaginal tension-free tape is that it avoids injury to the bladder, because I'm not going anywhere close to the bladder. But the problem is that I'm going close to all the major vessels, inferior epigastric हो, obturator vessels हो, accessory obturator हो सकती है. So there is a very high risk that I might injure one of these vessels, and it can be very dangerous. Whereas in a patient with TVT, there is a higher risk of bladder injury. So what we always do is, after doing these procedures, हम लोग एक बार cystoscope डालते हैं bladder के अंदर, and we see if there is any damage to the bladder that has happened or not. These surgeries are the most preferred surgeries, and they have been preferred until now. But there is a problem. The problem is that there is a body, a foreign body, that mesh that has been introduced inside, and this mesh can go and erode into the adjacent organs. And the most dangerous thing that it can do is it can erode either into the vagina or in the bladder, and that can lead to a fistula. So mesh complications are quite significant, which is also why these surgeries of mesh have been banned in the Europe, especially in England it is banned, but in America, in USA, these surgeries are still being done. My opinion is that if you're doing it properly, these mesh complications do not arise. If they were to arise, then removing the mesh is very difficult, because fibrosis would have started, and recovering that mesh from that fibrotic mass is going to be very, very difficult. So mesh complications are one thing, bladder injury and vessel injury are the others. This was about SUI repair with mid-urethral sling. If none of this works, or if there is something like intrinsic sphincter deficiency, जो मैंने पहले बताया था, when the Qtip angle does not move more than 10 degree, it is less than 10 degrees. So basically the internal sphincter is going to be the one at fault. In that scenario, I have one more option wherein I do something called as urethral bulking. So I inject urethral bulking agents around the urethra like this. I inject it around the urethra, and they help in compressing the urethra at its junction with the bladder. This is called as urethral bulking therapy. Durasphere, several things can be used for it. Durasphere is an example. So this can be done when everything else fails, or when you have intrinsic sphincter deficiency and you have to compensate for that. So this is it about the surgeries. Now, if you're asked in the exams whether which is the best surgery for SUI, your answer should be it depends upon whether the surgeon is comfortable with mesh repair or not. If you say that the surgeon is open to mesh repair and is capable enough of handling the complications, then overall the best surgery is going to be your TOT or TVT, whichever you can prefer. Whereas if a person is not comfortable using them, then Bursch suspension is going to be the best surgery that you can do for them. One more problem with mesh in a civil hospital is the cost. It is around 5,000, 6,000, so many may not be able to afford it. So in that case, you might have to do a Birch suspension, which is going to be cheaper than that. And then that is it from this session on urinary incontinence. If you all have any doubts, please ask about it to me in the comments. There is one small thing that you should know. There is a concept called as occult SUI. Occult matlab chupa hua, hidden SUI. So what often happens is often whenever SUI is present along with pelvic organ prolapse, the pelvic organ, when it comes out, whenever there is uterine prolapse, along with that uterus, even the urethra is pulled out. That urethra is going to be kinked. Kinked मतलब वो bend हो जाता है. वो bending के वजह से falsely the bladder neck is going to be compressed. So in a patient with prolapse, if you do not reposit the prolapse inside and then you don't do the Boni's test and then you don't check for the presence of SUI, you might end up missing occult SUI. So always, whenever you have a patient with prolapse, always reposit the uterus inside, keep it in situ, and then ask the female to cuff and see whether there is SUI because the uterus that is being pulled out, that is prolapsed, is going to pull the urethra and is going to stop the SUI from being shown. It is going to be masked. So always do it before, because once you do the surgery of hysterectomy for that female, vaginal hysterectomy, if you have not repaired her SUI component, she will come back to you with the complaint of SUI after your surgery for pelvic organ prolapse. So basically, you will unmask the SUI after the surgery and you will have to do another surgery for her SUI. So you can combine it in the same procedure by correcting the prolapse and then checking for SUI. So that is it from this session on urinary incontinence. It was an exhaustive masterclass, I believe. If you all have any doubts, do let us know. Do let us know in comments if you have liked this session and if you want us to do more of these. This is Dr. Aditya from Conceptual OBG signing off. I'll be online for your doubts for the next couple of minutes. Do ask him. And until then, good night. Dr. Aditya signing off.